Hi, everybody. Hopefully you can hear me. This will be my first Zoom lecture, so hopefully this will be a little bit better so you can follow along with me as I go through the slideshow. So let me know at the end of today whether this was better for you guys as far as learning, or if you liked the Facebook Live better, or whatever you are getting from this. So just let me know. But you're going to follow along with my screen now. There we go. So peripheral vascular surgery. I'm going to start with the basics. Really, I'm going to skip this slide for a second. All your diagnostic tests you should be familiar with. I put these two on here because they're very important, and especially in geography, that's going to be your gold standard for diagnosing these vascular diseases. But you need to know all the diagnostic tests that are on here. Okay, so the first slide. So I put this on here so you can see as you're reading through, some of these cases are going to be endovascular, so they're done percutaneously, minimally invasive, and then some of them are open. So anywhere that you see a graft or a patch, that's open. Anywhere you see a stent or a balloon, something like that, it's going to be done percutaneously, minimally invasive. So I'm pointing that out so as you read through, you see the difference between both. But these are your 4 different ways to intervene with lower extremity peripheral artery disease. So anywhere you see PAD, they're talking about peripheral artery disease. So after your diagnostic test, I go into the supplies. Before that, I want to take a look at instrumentation on 1083. So all I'm going to say is that it has, a vascular set, and then it specializes into a carotid set and an AV fistula set. The facilities I worked at were like that, but we also had the vascular clamp set. So it just had all of the vascular clamps that you see on your next page all together. So it didn't necessarily have all the names even on the count sheet. It just said vascular clamps, 30 total. So we counted them as a total item. So I'm going to go over the layman's terms when we get to those clamps so that you know the layman's terms, but make sure you're memorizing the names in your book too. Okay, supplies. So on this page first, it goes through, you're going to have one of every knife blade and Kittners to help get into those deep spaces to blot the blood, and lots of hemostatic agents, so Surgicel, gel foam, etc. So the next page is where it starts going through all of your clamps. So the note I want you to make, look at the names of these clamps. You're seeing DeBakey and Cooley, hopefully. So DeBakey and Cooley were both cardiovascular and peripheral vascular surgeons. They were pioneers for these surgical techniques, and that's why these instruments are named after them. So make sure you remember that as you're reading through this, your surgical history, that these are all atraumatic clamps. So hopefully you remember Tau clamps were traumatic and atraumatic, so think of it the same way. None of these have a traumatic end like a coker. They're all atraumatic, so we can clamp on a vessel and do an anastomosis and not damage it. So as far as the names, let's do layman's terms. So your first one, DeBakey occlusion clamp. So this one looks very similar to the Statinsky clamp, so don't get those mixed up, but it's still considered a DeBakey clamp. Letter B, DeBakey vascular clamp for aortic aneurysm. This one's easy. It doesn't look like the rest of them, and it's usually referred to as aortic clamp. And that is all. So that one's a little easier for you. The next one, aortic anastomosis clamp, is what I've heard it referred to as. So this one's the Lambert K. It says it in your book, vascular clamp for aortic anastomosis. So you can see the surgeons are going to use it for the same thing, even though they might use a different term for it. So if you know what they're going to use it for, it doesn't matter what they call it. You'll still be able to anticipate and hand them the correct instrument. Okay, after that, I want to look at letter D. So that's your DeBakey peripheral vascular clamp. For all of these DeBakey clamps, the surgeons I worked with, they just called them DeBakey clamps and then described it in some way. So DeBakey right angle, DeBakey 45-degree angle, DeBakey curved. So they were more describing the clamp rather than using these specific names. So just keep that in mind that they might describe it. So don't be ready for them to use these names. Just look at them and try to pick the right clamp that they're trying to describe. Basically the best that you can. A lot of surgeons, they have their routine. They're going to use the exact same one every time. So as a student, when you're with them, when you're with your preceptor, you can ask them which of these vascular clamps are they going to use. So you can go ahead and get those out, and then you can try to think of the specific name to try to impress your preceptor, but I'm sure they'll tell you, oh, he's going to call it a DeBakey clamp, or she's going to call it a Cooley or Satinsky. So they'll come up with a shorter name for it. So just keep that in mind. On the next page, 1086, you'll see that you have your little DeBakey clamps. I love those. So those are for your anastomosis. Make sure you know that these are countable items that are in your tray. So yes, you'll be counting instruments, and they're very small and easy to lose. So you're gonna make sure you're counting your bulldogs for anastomosis. Okay, so let's keep going with the vascular supplies. So that's what I have up on your slideshow now. So you can see, I didn't do it in the same order of the book, but vessel loops and umbilical tape to retract on vessels. Both of these need to be dunked in the saline before handed to the surgeon. You'll see at one point it says to put a vessel loop on the end of a tonsil clamp and dunk it in your saline. You absolutely can do that. That's what most scrub techs do. But remember, saline corrodes your instruments. So really you should only be immersing instruments in water, not saline. A way to get around that is you can clamp the vessel loop on the end of the clamp, let the vessel loop stay in the liquid, and let the clamp hang out on the outside. So there's ways around that, but vessel loops and umbilical tape used to retract blood vessels need to be moistened. The next one pictured are your pledgets. So for this one, you need to make a note. So your pledgets are basically a bolster anastomosis for friable tissue. So look at your picture. So this prosthetic is friable tissue because we just took a huge chunk out of it, right? So we took a piece of that aorta out, so probably for an aneurysm, right? Aortic aneurysm. Remove a big piece, and now that tissue is very friable. So as we're anastomosing with that very small suture, it could just tear through that friable tissue. So we're going to use pledgets to kind of pad it and bolster it as you're doing this anastomosis. So that's what your pledgets are. Let me go to my next one. So after this, I talk about vascular tourniquets. So these are typically called Rimmel vascular tourniquets. You'll see on the end, they have umbilical tape that comes with it. So make sure you're communicating on how you want to count that. The ones I use usually came with one umbilical tape. So you need to see how many are in there and whether they're counting it as a vascular tourniquet or vascular tourniquet with umbilical tape. You know, they might count it differently per facility. So make sure you're communicating that. Next are your Fogarty catheter. So it's definitely different than a Foley catheter. We're going to stick it in a vessel, then blow up that balloon behind the embolus or thrombus. And then when you retract that catheter, it's going to pull that embolus and thrombus out. So that's how we are removing these blood clots. So after a Fogarty catheter, I talk about suture booties. So suture boots, suture booties, suture tags. I've heard a couple different names for it, but suture booties, suture boot aids are typically what they're called, but they're always bright yellow and they go on your straight hemostats or mosquitoes. So this is for anastomosis. So you see that your suture is double armed, and you should already know that. So while they're working on one side, they might want to put a clamp on that friable suture to mark it so they don't lose it because it's so small, right? We could be using a 7-0 suture on one of these anastomosis. I've shown you that in class, and it's like a strand of hair. You can barely see it. So they're going to put a clamp with the suture boots on that suture. So this is protecting the suture. It's not going to damage it, so that anastomosis is strong. If you just put a clamp on that suture, it could damage the suture, and then that repair could come undone just because you put a clamp on a suture. So suture boots, very important. Of course, you're doing vascular, there's going to be lots of bleeding, so hemoclip appliers. So hemoclip appliers you have to load up are right here. These are sterilized, come in your instrument trays. These little cartridges you're going to count. Do you count the individual clips? No. You count this plastic cartridge because it could somehow end up on the field and inside a patient's belly. So we're going to count these cartridges, and then you can look at this hemoclip applier disposable. Some of these disposable ones, none of it's counted because there's no cartridge. It's all ready to go. So you're not going to have to load up clips. So these are what I call cha-chingers because it goes cha-ching every time you throw a clip out. So those two you need for sure for vascular cases. And then last is my angiocath with a syringe. So this is for heparin irrigation I put, but this is, remember, all different quantities, right? So heparinized saline, you have to write down the exact quantity so they know how much heparin's in there and how much saline's in there. So if any of the stuff says heparin irrigation, it's talking about heparinized saline. Okay, so those are some of your supplies, but I got more. So underneath those supplies, I didn't really hit the suture. I didn't put a picture of that because you don't need it. But on the list of all the suture, pay attention to the ones that are the same. So like look at femoral and popliteal. We're both working on the legs, so the suture is the same size. So 5/0 or 6/0. Instead of memorizing what size goes with which part, I want you to know that these are running, non-absorbable sutures. So these are all for anastomoses. They're running, non-absorbable. And again, if you're working on the leg, it's always going to be the same size. So 5/0 or 6/0 suture. Okay. So you should already kind of know some of the stuff. So it's kind of a review on some of these things, like how to do an arteriotomy, everything about anastomosis, the type of suture, all that stuff. It should be reviewed for you. So hopefully it's really sinking in and sticking now. So after the suture, now I can look at the slide. So now these are your synthetic grafts. The one I pictured is huge. So is the aortic graft, but they're all different. I wanted to point out that some of them are bifurcated, some of them are woven, some of them are not. So they're all a little bit different. Read through the details. I know you have a MindTap question about your grafts. So all I'm going to say is that they're all different. Some are impregnated with anticoagulation factors. Some of them are impregnated with antibiotics. Some of them are impregnated with nothing. So because of this, they all have different manufacturer instructions. So make sure you're following those. So some they're going to have you dunk in saline. Some they might have you irrigate the lumen with heparinized saline. So make sure you're reading the directions, as I always say. I love that all of our packages come with instructions on it. And they usually make it easy to read so the scrub tech can breeze through it really quickly while they're scrubbed in to see how to handle that graft. Again, you're going to be a student too, so your preceptor is going to tell you, so this graft we soak in saline, or this one we irrigate with heparinized saline. So you're going to be taught the proper way to do it, and a lot of the times, again, it's going to be on the instructions. So read the instructions for your grafts. I put everything on here for synthetic grafts, but let's look at your autogenous grafts in your book. So page 1087. So autogenous saphenous vein is typically what is going to be taken for lower extremity bypasses. So basically, we need to bypass something in their leg because they have an obstruction there. So we're going to do a bypass of the lower extremity, and it's almost always going to be with that saphenous vein. So make sure you know that. Read about where it talks about the in situ technique with the saphenous vein. So this one, they are basically taking the proximal and the distal ends and anastomosing it that way. So they're leaving some of that vessel there, so they're not taking as much. But basically this enables anastomoses for vessels that are usually too small. So it basically accommodates for those small vessels. So not everyone can take the full saphenous vein grafting, so that's why we have this in situ technique. So we can take just the proximal and distal ends and anastomose that. So if you read further down, it tells you it actually is better for the anastomosis. It comes better matched out that way. These advantages lead to better limb preservation, so better results from the surgery. So after that, I want you to read where it talks a little bit about veins, because we're still talking about our grafting. So in order for the vein to be effective as a bypass graft, the valves within the vein must be stripped. So this is an anatomy review. Your veins have valves and your arteries do not. So if they're trying to use this as a graft, they don't want that valve in the way, controlling the blood flow. We are putting this graft there for a reason. We want to control the blood flow of where it's going to go. So they're going to strip that valve away. So again, valves are only in veins, and we're going to have to strip that away. After that, as you're reading through this, just know that these patients are coming in with claudication. So hopefully you already know that definition after reading, but claudication is that deep aching pain in the lower extremities. So they come in with that pain in the lower extremities. They realize it's from an obstruction, so they're not having blood flow like they should to the legs. So this is your indication for peripheral artery disease. So throughout this chapter, you'll see they're having the surgery because of their peripheral artery disease. So this is typically how they're finding out that they have this peripheral artery disease in the first place. I think I hit all of it on that page, so go ahead and flip it over, 1088. So you'll see more pictures of your grafts like I have on here, and then I really get into the equipment. So here we are. So I'm only gonna go over 2 of them. So your Doppler and your handpiece, very important for any procedure that has an anastomosis. Sometimes they'll also use this non-sterilely before the procedure. So if they just want to check the blood flow before they do the case, they'll have a non-sterile Doppler also. So sometimes you need both. So communicate, read your preference card, know what you need. What is pictured here is typically the box is going to be non-sterile, whereas the handpiece is going to have a sterile cover on it. Some devices can be sterilized. So the handpiece will be sterile and you'll plug it into the box where it's non-sterile. So you treat it like a Bovie or a suction tubing. So all very different, but know what you need for your specific Doppler. And you'll turn that speaker up really loud so you can actually hear the blood flow flowing through the vessel. So what you want here is you do an anastomosis, and you know it's done properly when they put that Doppler over the vessel and you hear whoosh, whoosh, whoosh. You can hear the blood flowing and perfusing the limb. That's hallelujah, we did it correctly, and we can close up. So we love the Doppler for that, confirms that we're doing our job correctly. And then cell saver tubing. So I've talked about cell saver before for specific patients that don't want blood products. So in vascular surgery, a lot of the times, it's not for that reason. It's that we're going to be using and losing a lot of blood. So because we don't want to give them so much foreign blood products, we'd like to give them their own blood back. So we're going to use that cell saver suction tubing. So for you, I put a picture of the machine so you see what that looks like. As far as who runs it, it's all different. So some places, the scrub techs that aren't scrubbed in run it. Some places hire perfusionists just for cell saver devices. Sometimes other people are cross-trained in how to run cell saver, and you can get specifically certified in that too. So very cool, but typically we're scrubbed in when we are using the cell saver. So for you as a scrub, you need to know, I need to have cell saver tubing to go with the cell saver. So it's specialized suction tubing. It's not going to look like your regular suction tubing. So again, read your preference cards and see what they're going to need for that case. So here's your equipment. Headlight and loops, this is equipment for your surgeon really. I'm pointing this out so you can see that this box might get in your way. So a lot of these cases you might have to move around some. So you might start on the right side of the patient and you end up on the left side of the patient because that's where the surgeon needs to be. You might switch spots. So because of that, they've got this huge headlight on, and these cords are hanging behind their gown, and it's plugged into this light box, this light source. So when they go to change spots, usually they pull and they forget they're plugged in, and they have to say, hold on, hold on. You're gonna knock the box over. You're still plugged in. They have to unplug them, let them walk around. Of course, we're just touching their back. It's non-sterile anyways. And then we're gonna have to plug them back into the box. So that's usually something the circulator has to do. They're chasing the surgeon around the field to plug their light back in. So look at your surgeon. They've got loops on and a headlight. And a lot of these cases, you're going to be wearing lead. So if you think you're uncomfortable just wearing the lead, take a look at your surgeon. And what they're doing is literally life and death decisions. So hopefully we can take a second and appreciate these vascular surgeons because they work very hard every day. But they'll be wearing loops and these headlights, so be aware of that. Okay, after your equipment, I went right into the anatomy. So the procedure is angioscopy. So that's on 1088. And I put the page number for you, but I want you to review this anatomy. I'm not going to go over it for you. So you need to know what capillaries are, and I've taught you that, so I know you know it. You need to know this picture right here. So you need to know that oxygen and waste products basically are being exchanged here. So we're exchanging oxygen and metabolic waste. So hopefully you know that term already. And you know that that's happening, but you need to review all of this stuff. So basically everything that happens in the capillary bed, you need to know what's happening with the fluid and how that's working. So it's got a good picture on 1089, but if you don't like that picture, I've got these two on the slideshow and one more so you can see where the oxygen and nutrients go versus the waste products. Okay, so let's get into the procedure instead. So angioscopy, you're going to typically be diagnosing, but you're looking, they usually find an embolism or something like that, something that they might have to do a vascular bypass for, or they might not find anything, but this is typically diagnostic, so angioscopy. So we're sticking a scope through the vessel to take a look at this. So I want you to know what's the primary challenge for the surgeon. So primary challenge is clearing the blood from the visual field. So just like a lot of scopes, you're going to get blood on that scope and you can't see very well. So that's the biggest issue that they're going to have with this case. As far as diameter, look at that part. So I'm on 1089. So an angioscope that's smaller in diameter is going to avoid vasospasm. So it's not going to irritate the vessels. They're not going to start moving and spasming. If you get an angioscope that is too big, it can cause vasospasm, number one, but it can also irritate all the tissue as it goes through. So it could damage that inner tissue of the vessel. So that tunica, the inner layer of the tunica is what's going to be hurting. So again, it's also going to cause vasospasm. So the surgeon's going to want to pick the correct size angioscope to prevent that. I'm not going to go through this procedure because, like I said, it's diagnostic. So we're making sure that the blood is flushed away so that the surgeon can really see as they're going through this. So you'll get to see whatever pathology they find to diagnose this patient. Let's go ahead and go to the next procedure. I skipped this picture for you. This is just another picture of the same thing so you can study your capillaries. Okay, so I just did angioscopy. I didn't go to the slide yet for a reason because there's a couple of procedures in here that can be done in the hybrid OR like angioscopy. So hybrid OR or IR or cardiac cath lab. The reason it's so many different names is it depends on the hospital. So big hospital, I'll give my two examples of my work experience. So big hospital, we had a separate floor for IR, cardiac cath lab, interventional radiology. Anything endovascular is done on that floor, never done in the OR. I go to a small hospital, we do all of these cases in the OR because there is no angio suite. So it just depends on what your hospital has for you. So any of these cases that I put hybrid OR, IR, that means if they have a hybrid OR or an IR or a cardiac cath lab. So basically your endoscopy area. If you don't have an endoscopy area, you're going to be doing it in the OR. So basically they make do in these smaller ORs. Okay, so now that you see where they're going to be doing the angioscopy and any of these endovascular cases, let me go ahead and go to our next case. So on page 1090, so I put what it's really going to be called, a central venous device. So your book says insertion of a long-term interdwelling central venous catheter. Whew. CVC is what you need to know that as. So this is insertion of a CVC. So people know this as central venous catheter. That's typically what's going to say on the OR board. So this is AKA a central line. So that's another note that you need to make. This is a central line. Now, usually when we say the term central line, we're talking about anesthesia. Anesthesia is giving the patient a central line for this procedure. This is not what this is talking about. This is talking about giving, it specifically says long-term interdwelling catheter. So it is a CVC, central venous catheter, but this is for long-term. This is for the patient to go home. So we're used to hearing central line from anesthesia to treat the patient. This is so the patient can go home and not be in this hospital anymore. So let's go over what they can use it for. Administration of chemotherapy, antibiotic therapy, IV fluids, and pain medication. So again, CVC so that we can take it home. So central venous catheter to take their IV medications at home. So I want you to know what that catheter is going to be. So it's a Grosjean catheter, typically 12 French, but that depends on the patient, right? And this is always going to be double lumen. So that's what you need to add. A double lumen Grosjean catheter. So this again is for your CVCs. So this is always going to go, look at your number one, your procedural consideration. This is always going to go in the right subclavian vein. Now it gives you an alternate space if something's already in the right subclavian, and it's the left subclavian. So they're going to always put this on the subclavian vein, and they're always going to use fluoroscopy to verify that they are in the correct spot. Okay, that brings me to the anatomy on the next page. So you can see the anatomy, so you can study that. And then all of this is just so you can see how the catheter works. So do you need to know all the little pieces of this? No, I just wanted to help you understand what the catheter looks like and how it's going to be used at home for these patients. Okay, Now, angioplasty on 1092. I try to put page numbers on here for you guys because I know we're learning online and it makes it a little bit harder. So I'm trying to make it a little bit easier for you guys. So 1092, angioplasty. So again, angioplasty, just like our first procedure, can be done in the hybrid OR or in the cath lab. So I didn't put a picture this time, but hopefully you learned that from that first diagnostic procedure, your angioscopy. Hopefully you already know angioplasty, angioscopy is going to be done in the same place. So if they have it, cath lab, IR, endovascular area. So I want you to know what we're treating first of all. So we're treating that plaque, but I want you to know the technical term. So to treat arthroscopic thickening, I knew I would mess up one of these on my Zoom meeting, but I'm not going to re-record. So again, your atherosclerotic thickening is going to happen. So that's your plaque building up in your vessels. So this is what I've always talked about. And when I get to carotids, I'll talk about it some more. That's removing that big hunk of plaque, and it's going to look like a French fry coming out of there. So that's what we're doing in this procedure. The next part is the anatomy. So I didn't put another picture because these have good pictures in your book actually. So study your anatomy, know your 3 tunics of the artery wall. So basically you're learning the artery wall anatomy, and it's got 3 different layers, and you need to know all 3 layers and what they do. So I'm going to pick one and focus on that one to give you an idea of when I say know what it does. So look at your tunica media. So this one's the thickest layer, and because of the muscles, it's going to be in charge of vasoconstriction and vasodilation. So this is very important because, as you know, every time you take a step, those skeletal muscles contract. So this is why we want to keep the blood flow moving where no blood is pooling. We want that constriction and dilation to keep on happening. So that's just one layer, but know all the layers and what they do. As you keep reading, so know all the layers, know vasoconstriction, vasodilation. Find the very bottom of the page, 1093. So arteriosclerosis obliterans. So this one is specific. It's a common disorder of the arteries characterized by thickening or loss of that elasticity of the walls. So basically, in addition to this plaque, we're losing elasticity of the arterial walls. Because of that, it's going to be harder to repair, right? It's going to be harder for it to take a stent or a balloon. It's going to be harder for it to take a graft if we were to do something open. So make sure you know that part, because that's a little added piece in there. Then know what usually occurs with atherosclerosis. So this usually occurs when you're getting older, so with age. Tobacco use, hypertension, obesity, diabetes mellitus, and high levels of cholesterol. So all of these things can basically increase your risk of having plaque inside of your arteries. So to deal with this, we are going to do an angioplasty. So look at your equipment, instruments, and supplies. So you need an angioplasty balloon catheter tray. So everything it lists there, that's everything you need. That's already in a kit altogether. So typically there's a kit that you're going to open, and it's going to have that guide wire, the catheter, the angioplasty balloon, all of those things. But it's going to be all together for you. So you'll have a specific tray for this. And then of course the stents. So as you're studying the stents, know what they're made out of. So stents are made out of stainless steel, titanium, or polypropylene. As you're reading, hopefully you're seeing what this is doing for your patient. So it's not just the plaque is causing an occlusion. There's other reasons why we have to get that out of there. So the plaque places the patient at risk for thrombus, coronary heart disease, lots of other things, and heart attack. So your book only lists a few things, but basically this plaque is putting you at risk for so many other pathologies. So it's not just the blockage, like when I talked about claudication, not being able to feel your legs as much and having resting pain in your legs. It's not just for comfort. This could cause a heart attack for your patient. So this puts your patient at high risk for blood clots. That's why we're here doing an angioplasty. Okay, so this specific procedure is talking about putting in a stent. So hopefully you've read about stents now and you see what we're doing, but they all start with this guide wire. So no matter what, on any of these endovascular procedures that are usually done in IR, you need a guide wire to start, because everything they're going to put into a vessel is going to go over that guide wire. So that is helping us do the entire procedure, this guide wire. So make sure you know that you need that for the procedure. Instead of going through this one step by step, I want to stop at page 1095. So the very beginning of the surgical procedure, know that this coronary angioplasty can be done to treat blockage of the coronary artery. So that one's very specific. This is talking about an angioplasty anywhere in the body. It's throwing that at the top of the surgical procedure for a specific one, so specifically for coronary artery. As far as you as the script tech, so the surgeon usually picks out the size of this balloon, but you still need to know why the size is important. So selection of the balloon that is too small could underdilate. So then the stenosis is still there. We'll just have to come back and do this case again. So you don't want it too small. And then if you do too large, you could actually damage the vessel and dissect that vessel. So open it back up. That's even worse. Of course, you're causing more damage. So you don't want to dissect that vessel. So Goldilocks size, not too big, not too small, just right. As far as the balloon length, that is something that you need to know also. Balloon length should be sufficient to extend 1 to 2 centimeters beyond the lesion. So they're usually measuring, okay, how far is it to what we want to remove? Thrombus, embolus, something like that, or a lesion. And so you want to do 1 to 2 centimeters beyond that, so they can go beyond that lesion and pull it out. Look at number 1 in your surgical procedure. Again, they're being very specific for coronary angioplasty, but I want to point out that this is usually done with the femoral artery. So lots of things that are done in endovascular surgery are done through that femoral artery. So it's just really good access for them to get to the heart and to get really anywhere else in the body that they need to through that femoral artery. So I'm not going to go through that procedure. Know that they typically do through the femoral artery. Okay, so you can see a picture of your stent with your balloon angioplasty. So you can see how that's going to keep the vessel patent or open. And now I can go to embolectomy or thrombectomy. So know what an embolus is, know what a thrombus is. I'm not going to go over the difference between those. You should 100% know the difference because I went over it a lot. So these pictures, this is how we're going to remove it. So again, we're going to use these Fogarty catheters to remove it. It's got to be 2 centimeters longer, like I said. So it's got to get all the way to that clot, so then we can blow up that balloon and pull it out with the catheter. So these are going to be minimally invasive if we can in the angio suite or cardiac cath lab. And again, we always start with that guide wire, and anytime we're using that guide wire, we're going to have fluoroscopy. So let's look at page 1097, instrument, equipment, and supplies. So you're definitely going to need the Fogarty embolectomy catheter for this one. As far as treating this one, so you need to pay attention to the fact that we're not just treating the embolus. They're going to try to find out what the underlying disease was that led to the formation of this in the first place, whether it be they have high cholesterol, maybe they have history of blood clots in their family, whatever it is, they're going to need to find out what that underlying disease is instead of just removing this thrombus or embolus. So they're going to get down to figure out what caused this in the first place. Okay, so you know your equipment and supplies that you need, pretty easy. Heparinized saline and that catheter, maybe some vessel loops if you get that open. But I want you to know what they can do for non-surgical patients. So find where it says for the unstable patient. So that means they're not suitable for surgery. They're not healthy enough to withstand surgery. So because of this, of course, they're going to get anticoagulants. We want to stop that coagulation from happening, no more blood clots, and get that stopped as soon as possible. I want you to know medication-wise what else they can do to treat it. So we want to do enzymatic lysis of the embolus. So just like I've always talked about lysis of adhesions, we're getting rid of that. So lysis of the embolus. So we want to break up the clot. So if you want to turn this confusing part of the book into a little bit English, I will help you. So find where it says more recently enzymatic lysis. So more recently, enzymatic lysis of the embolus has been advocated. So I want you to know the two terms that they're going to use. So urokinase and streptokinase. These are the names of the two enzymatic medications they're going to use to break up the clot for that lysis. So they want to break up that clot to get it out of there. Okay, so now that you know the non-surgical, let's go to surgical, and I'm going to skip to the good part. Because you know that if they're doing it minimally invasive, it'll be what I was just talking about, everything they're doing in the endoscopy suite or cardiac cath lab. So let's say it's open and it's not endovascular. So I want you to look at 1098 number 5. So they're going to use that 11 blade to do an arteriotomy. Hopefully this review for you too. After they do that arteriotomy, they're going to extend that incision with those Pottsmith scissors. After that, they're going to use that Fogarty catheter to pull that embolus out. So again, we can do this open or we can do it endovascular. There's lots of options for you. And that's my last slide for that one. So I will be back with the next Zoom so that you can see the rest of the Chapter 23 peripheral vascular surgery. So I'll be back soon.